there's two aspects of telehealth that I'd like to ask you about. The first, operationalizing telehealth, and the second being data silos. So, so you gave us some background on the program and what you rolled out. So let's just dive into those two things. So the first thing, which is operationalizing telehealth. It's not as much a technology challenge as it is an operational challenge, getting everyone to understand how to really utilize this technology, where it can be utilized. Give us an idea of the process that you went through, how you determined the best places to put telehealth, and then how you brought the clinicians along, and then also how you got adoption out in the field. I guess those are the key areas for operationalizing.
Telemedicine has been around for a while. You know, Michael Crichton wrote in his book, 5 Patients in 1969 about a use of telemedicine at Boston Logan Airport for a patient who landed who was having chest pain. And they used telemedicine to connect that patient to Massachusetts General Hospital. So this is going on 50 years now. So it's not really the technology that's developed that far, it's how we use it. And certainly the technology is more ubiquitous now, but it's really the use cases. And so the way at New York Presbyterian that we've been able to maximize our ability to use telemedicine is in thinking about those use cases that might best fit what's available and then try them out. So we've done a lot of fast failure. So our chair of emergency medicine, Dr. Rahul Sharma at Weill Cornell said, I'd like to use telemedicine in the emergency department. And we said, great, let's put together a small trial. We tried it with 10 patients. It went really well. We tried it with 20 patients. It went really well. We bumped it up to 50. We got feedback. We tweaked it. And now we're more than 20,000 patients into using it. We found it's much more efficient. Similarly, we found that trying it in nursing homes was very good because we're able to prevent patients from coming in the middle of the night who could otherwise stay in their nursing home. But it doesn't scale really well. It's really challenging to get nursing homes that might only use it once a week or even once a month to use it with any frequency and use it really well. So in some areas, we found that we've really taken to it, in other areas, not so well. So our ability to get to 100,000 visits a year is predicated on the idea that we found 12 to 15 use cases that work very well, very deeply with those.
Wow. Are you using a lot of specialty equipment, or are you just basically using a pretty basic set of tools on both sides of the equation?
The fact that we've been able to maximize our success in telemedicine is based on our ability to be nimble. So we've used many different tools for different areas. So our ability to do second opinions nationally is in partnership with a company called Grand Rounds. Our ability to do telemedicine psychiatric evaluations in our emergency department is based on our ability to use our own Cisco equipment internally, so nothing special. We've partnered with American Well to be able to do our telemedicine visits via kiosks and on our phones. And in other cases, we've just used our own network. So there's no one tool or technology. It's the ability to use the right tool at the right time and be thoughtful about it.
That's awesome.